Hello dear colleagues and friends, this is episode number 8 from our BG Dental cases. My name is Belograd and I'm really happy to meet you again. This time we will have a really special, very ninja, very hero endo case. Very super minimally invasive, crazy case actually. Very crazy case. And we share these cases because a lot of participants and a lot of colleagues, they ask about endo related cases, and in this case I will show you a lot of tips and tricks how to deal with a really difficult, super difficult cases, especially when you have curved root canals. This is what we will be discussing today with you. Before we start, I would like to say that this time we will do also contest, okay, with a very special prize. We will give you free of charge participation in our online masterclass about rabberdam isolation. And to be able to win this participation, you have to answer one question. So the question is, what kind of technical features of instruments make them to be flexible and make them to be useful in curved canals? In other words, when you work with a curved root canals, what type of instruments you will use? You have to answer and to name at least 3 technical features of instruments, okay? 3 technical parameters of instruments. Okay, let's go. So type your answers in comments, and among all who will give us correct answers, we will make a quiz, and next Monday we will define winner. Let's go. So this is very dramatic case. Pretty old one. It was, I don't know, maybe from 2008 or 2009 when I was younger and more crazier, but whatever. That time I made fixed bridge to one of my patients. His tooth was vital, and he had before my treatment, he had before an old bridge. So we removed this old bridge and made a new one, made of zirconia bridge, okay, to be fancy, nice, white, whatever. I prepped his tooth for new zirconia bridge, then I bonded this or fixed or cemented actually. I cemented the zirconia bridge, and then 2 days later I got a phone call from this patient. He was in severe pain. He said he cannot sleep, he cannot eat, he cannot live, everything is super painful, pain is so severe and long lasting, so I was just trying to find out solution. And the problem is that my schedule that time was pretty tight and I didn't have a room for that type of patients. But next day I got a group of colleagues for my office course. That time I did office course, live patient office courses, endodontic office courses, and I scheduled one patient for demonstration. But that patient that I scheduled was not in pain, so it was like, you know, the regular patient that we can reschedule. But that one was in pain, and I said, okay, I will definitely help you. We will treat your tooth, but you have to be ready that there will be colleagues, like a supervisors, and I will be doing your case, and they will see, and I will comment, etc. He said, do whatever you want, just do something to get out of this pain. Okay, and I was pretty happy because look, it was vital tooth, pulpitis, lower premolar, which is simple tooth to be treated. Okay, then he came, we made anesthesia, then I made 2 x-rays. On the first one everything was not so bad, but when I made another one I saw that there was a root canal. Here is the root canal, and then root canal disappears. In such a cases you have to be aware. In such a cases when you cannot see there was root canal and then it disappears, it's not obliteration. It is not sclerosis. It means that you have additive root canals. Okay, and according to statistics, we know that there are some of lower premolars that have two root canals. One is buccal, one is lingual. This is classic two or double rooted or double canaled lower premolar. So I was ready for that. And here is my bridge, my crown. There is a small tip for you in case when you need to isolate bridge and to do something with bridge. In this case, I will be doing endo. So we do regular isolation, and then we take flowable composite and we fill everything around with flowable composite just to prevent leakage. Another tip, which is also important, is that when you have to do root canal treatments through the crown, especially metal crown or metal ceramic crown, we have to be aware of interference between your file and metal area when you are doing, when you determine length of the root canal utilizing apex locator. Because if you will touch with your file metal area of crown, your apex locator will not work properly. Okay, so in this case you have to isolate this metal, and the way to isolate is pretty interesting, pretty simple. Just imagine this is our axis. Okay, this is our axis, and metal around. So what we can do, you just take your flowable composite or normal packable composite and just put your composite around, inside and outside, just to block metal. So with composite you are creating isolator for metal zone. Okay, and then you can use your apex locator and everything will be okay. Perfect. But what I would like to say that I'm not a big fan to do root canal treatments through the crowns, especially the old crowns. In this case I had to, because this is just fresh cemented bridge. I did this bridge. I know that there is no caries underneath. I know that there is no crack underneath. I'm responsible for that tooth because I saw that tooth before I placed the bridge. Because sometimes when patients come to our office and saying like, I have a pain but I have crown, can you do something, etc. I'm not sure what is underneath this crown, because you can do root canal treatment, but at the end of the day, if there is a lot of caries under this crown or there is a crack line or whatever, you cannot save the tooth. The treatment in this case will be not complete. Okay, it will be manipulation but not the treatment. Anyways, let me go back to the endodontic treatment. So I was ready to have two root canals. First root canal was negotiated in very easy and simple way, just straight and then go. Another one, perfect. I was happy, I was proud of myself. I was speaking to my colleagues, let's say, look, two root canals, lower premolar, we are really ready for that. But then I started to realize, to analyze, to evaluate the image that we have. And then look, just take precise look what is here. Okay? I noticed that there is some additive shadow all over here and all over here. Okay? And I was in trouble. To be honest, I was in trouble because I started to understand that there is something else. Okay? There is a tip. When you do root canal treatment and then you put your file inside the root canal and then you do X-ray, you have to see if your file is centered in root canal. Because if your file is not in root canal but in root, if your file is on peripherally oriented, you have to understand that in most of the cases there should be another one. But in our case, look, here we have something that has to have extra root canal. Okay? And the problem is that this root canal would be from curved aspect of the root. So that means you cannot get really quickly and really easy inside this root canal with your normal preferable instruments, because these two instruments were negotiated and were instrumented with the nickel titanium rotary files in very simple and fast way, but these ones were under the curvature. So what I did, I took hand file. One of the best choice, for example, for that type of cases, when you negotiate with ledge or you negotiate with sclerosis, when you negotiate with the curved root canals, is to use specific hand files like a C+ file from Dentsply or C Pilot file from VDV. They are strong and they give you possibility to get some slight apical pressure if you need in the accurate way. So I took now my hand file number 10, I pre-bended the tip of the file, and then I started to negotiate root canal system. In this case, during even analyzing this X-ray, you can understand where to direct your file. So we have to direct our file mesially to canine, and in most of the cases also lingual. So mesolingual direction of the file that you will be utilizing. I would like to give you one more trick, which is simple trick, but maybe we have students here and or young dentists, and maybe you don't know that. So I would like to share this with you. Just there are, you know, silicone stoppers in files. Let's say they are yellow, like this, silicone stopper, which is simple silicone stopper on the file. And some of the files, they also have some lines, some marks on stopper, like white line or maybe black line or whatever, or some stoppers, they have some extension. Okay, let me go back to this. Yeah, some extension like this one, for example. So this is what we use to negotiate and to understand where is the curvature. For example, you pre-bended your file, and then you take your stopper with this line, this mark, and then you turn this mark straight towards the curvature. So when your file in root canal visualizing this mark, you'll be able to understand where is the curvature of the file. So it will guide you. Okay, so I put my file in root canal and I went there and then I started to negotiate the root canal, and I was pretty lucky. I was able to find this third root canal. It was curved, but I was pretty lucky, and then with the 10 file I went to the working length, then I went back, then go back again, go back again, etc., etc. So with this up and forward, up and down movements, just to find out the correct way, the correct angle of file insertion. Okay, but then suddenly, accidentally, absolutely accidentally, I noticed that when I was trying to go back again with another file to that root canal, I got another direction. So it was not the direction that I found out already and I memorized it. I found another direction, another different angle. So I was about to think if it's another root canal, or maybe there is, you know, there is a specific feeling when you have your file in root canal, especially in a narrow root canals, and if you push your file and the tip goes into the wall, and then the tip goes like this, so you fold the tip accidentally. In this case, the diameter of the file will be increased by double, so it's now like this. And you may get the feeling that your file in the root canal, so you're still instrumenting the root canal. So in that case, to check it, I just took my file out, and I saw that the file was still bended, no problem was with the file, and then I went back, okay, for this new direction. Then I took this file out, turned, went back to the previous direction, and I was able to go there. So I was actually about to find another 2 root canals instead of 1. So instead of 3, we have got 4 root canals. And I was sweating, because imagine colleagues are in the room, I explained them that we are about to find the 3rd root canal, but now I have 4. And I understood that except of finding this root canal, we have to instrument this root canal, we have to irrigate these root canals, we have to obturate these root canals, we have to complete endodontic treatment, and these 2 were super difficult. You know that feeling that somebody is watching you, professionals, and you have to show your best, okay? I was sweating like, I don't know, I was under the rain. Anyways, we got this information from these directions, and I will share with you tips and tricks how to negotiate that files. The access that I made is this. I was really super crazy in terms of that minimally invasive access that time. It's exaggerated maybe access, but to be honest, you can use this type of access, and you even can remove the pulp from the coronal part with ultrasound and with sodium hypochlorite. You can clean pulp horns, and you can negotiate straight root canals. You can. But in that case, these 2 additive root canals were under the curvature, and we were not able to see them. It's impossible, okay? So, how to deal with such root canals? It doesn't matter if you have this axis or another. If I will make this axis, I will be not able to see these root canals either, because they were at the wall area. They were not straight, they were at the wall. So I was not able to see them, even with a big axis, I'm pretty sure. Anyways, so what we made, I took my hand file number 10. Then I went to the working length. There is a small tip. If you are able to go outside just to periodontium, just like 1 millimeter out, it will be good in such a case, because by going through the root canal, you are making the shaping of apical portion of the root canal by taper of your file. In other words, the regular hand file has taper 2, okay? That means that, for example, file number 10, at the tip it is 10, but having taper 2, this file 1 millimeter coronally will have size 12. Then 1 millimeter more, 14. 1 millimeter more, 16. Because taper 2, you have to plus to the native diameter of the file. So that means if you will go through the root canal with this hand file number 10, apical part will be 12. Okay, and then 1 millimeter coronally it will be 14, which means it will be easier for you to utilize file number 15 later on. Okay, and there is one more trick. You go with your file number 10 or 8, depends on the case, go there, and then you take it 1 millimeter shorter, and then you go up and down, up and down, up and down, up and down, but don't force it too much down. Don't force it until the tip of the file will get resistance. The tip has to be in air. The tip has not to be in interference with the root. And these up and down movements, like a brushing technique, will enlarge the root canal by scrubbing the dentin from the curvature areas. Okay? You have to do these movements until you will feel that file loose in root canal. It's not stick in root canal anymore, it loose. But again, the tip of the file has not to have interference. So there should be some distance after this tip. That's why you go working length, 1 millimeter shorter, and then you go. Okay, then you go, then file loose, you take it out, irrigate. Then you take another file, you go there, 1 millimeter shorter, then up and down, and then you can take another one. So in this case, we instrumented these root canals, these 2 curved root canals, with hand pre-banded files. But the problem was that we were able to get only taper 2 because of the design of the file. But there is another trick that I would like to share with you. You can create greater taper utilizing files with taper 2. For example, in that case, what I did, I end up with file number 25. Then I took file number 30 and I moved this file number 30 1 millimeter shorter than working length. That means that now we have at the apical area size 25 and 1 millimeter coronally we have 30. Then I took my file number 35 and put it 1 millimeter shorter than 30. So we have 25, 30, 35. And each step is 5 points. 25, 30, 35, 5 points, which means we have created taper 5. I hope you understand this. If you understand this, please write down in comments now, yes, I understood, because I know that we are not live. It's in the record, but it will be nice to see interactions. Okay, so if you understood, just write down I understood, and I will see these comments. I will be pleased. Thank you. Okay, so we created this taper, and another thing is just I will show you after obturation. So you can see now obturation, and these two root canals. One is here, one is here. One is here, one is here. These two straight root canals, 1 and this is 2. 1, this is 2. So 1, 2, 3, 4. And this one is a bonus. It's a lateral root canal. It's not the one that we were able to feel or to touch. It's absolutely like incredible anatomy here. So after instrumentation, we had to irrigate, and in this case it was pretty difficult to insert our needle for irrigation to that portion. It was super difficult. So there are some tips again to share with you to be able to irrigate in such curved root canals. First, we are using sodium hypochlorite because we need to dissolve soft tissues. But we know that the sodium hypochlorite itself, it's not so fluid. It's not like even like water. It's not going into the small tiny spaces. You have to push it. You have to force it. But in this case, if you will force it with a good aperture or with a files, it may not help you. So there is a solution. There is an irrigant, which is ethanol or alcohol, that is proved that can guide your sodium hypochlorite to these tiny spaces. In other words, if you will irrigate root canal with ethanol that has a really minor surface tension, it will go really in small, tiny, narrow spaces. And then when you will be using sodium hypochlorite, it will be delivered the same way where the ethanol is. Okay? So we irrigated root canals with ethanol. Then I took files and I moved my ethanol with hand files to that root canals. Then immediately I took sodium hypochlorite, irrigate, hand files, then again sodium hypochlorite, then irrigate, hand files, and then ultrasound activation. In such a cases, you cannot use ultrasound in such root canals. You can use ultrasound in straight part of the root canals. But if you would like to get really efficient way of ultrasonication, there is another tip that I would like to share with you. You can take your hand file, put this hand file to the working length, and then you take your ultrasound tip for calculus removal, for example, and you just touch with this tip your file. So there will be indirect ultrasonic activation of your solution by ultrasonic device. So that is safe, you are not breaking the file, and you are in the root canal, and you are in the working length, and everything is super perfect. And we repeated these actions many times just to be sure that organic tissues will be dissolved. Then, drying of the root canal. In straight root canals we can use paper points, but in the curved ones it was super difficult. I was trying to put in the paper point, then it was bended, then I was nervous, etc. So what I did, we injected or we irrigated root canal with ethanol again, and you know when ethanol evaporates, it takes also extra liquid. Okay, so we put ethanol, then we take our handmade endo last time during episode number 7, I was showing you the way we do this hand endo vac. If you didn't see the previous area, you can see all our case reviews using this link. So on this corner, when I'm showing you finger, there is a sign to the playlist. Okay, so you can see all the cases that were already published. So anyways, we put ethanol, hand files to deliver ethanol to the working lens. Then we take our thin needle for calcium hydroxide dressing. We apply this needle to thin suction, and then we put the suction system into the root canal, and it evaporated ethanol and also evaporated some moisture. Even though I'm not 100% sure that I was able to drive complete root canal system, I was not pretty sure that we were able to dissolve organic tissues as well. But we tried our best in such a case to make everything perfect. Okay? And then we went into obturation. And obturation was also super difficult because it's not that easy to insert master cones to that root canals. Imagine there are 4 root canals, and the split is in a real small space. The 2 and 2 more, it's really crazy. So we decided to go for backfill technique. We took sealer, pretty much sealer, with files. We moved this sealer into all these root canals, and then I took my gutta percha gun and I injected gutta percha above this split. Okay. And then I took hand plagger and pack. So we create some forces. And then I took hot plagger, and then I made down pack. So I took hot plagger and then I made down pack, took out this hot plagger, took the cold one, pack again, then put some sealer, inject the gun with gutta percha, then again hot plagger, down pack, packing again, and these 3 times. So we did backfill, down pack, backfill, down pack, and backfill, down pack. So we created pressure, and gutta percha and sealer were forced to these tiny spaces. I'm not sure that we have gutta percha everywhere. Maybe here is gutta percha, maybe here it is, but maybe this is just sealer, just sealer. I don't know. You cannot predict this. The only way to predict is to extract this tooth and to see it from another side. But we did our best. We did our best for instrumentation. We did our best for irrigation, for drying, and for obturating such a difficult root canal system. Okay. I gave you a lot of tips during this case review. I would like to remind you about our contest. So you have to answer question: what technical features of files give us possibility to use them in root canals? You have to name at least 3 technical features of files, okay, like taper or whatever, like this, 3 different features. And we will define winner next week, and you will get our free of charge participation in online masterclass about rabberdam isolation. If you want to upgrade your skills in endo, I would really suggest you to attend our module 4 from endo to resto. This is 100% hands-on course, absolutely practical. Just 1 day, just for 7 people, just full process from A to Z. There is no theory, there is no scientific data, etc. The goal during this course is to give you a really practical upgrade, and to make you to be able to do root canal treatments after this course. That's why it is absolutely hands-on, from morning to the late evening. Module 4, Module 4 from endo to resto. You can see link below this video, and you can sign up just for this course. If you are not interested in preparations, for example, you can go for that course. But by the way, during this course we do preparations. So it's a course about primary endo retreatments, and we do also preparations for ceramic overlays during this course. Okay, so my friends, don't forget also to subscribe, to follow us on YouTube, to switch on notifications, because we're preparing for you a lot of new content, interesting content, and I hope you enjoy that format of communication, that format of dental education, actually free of charge dental communication and education with tips and tricks from BG. And see you guys next time. Bye bye.